Hi, my name is Dr. Wendy Woodward. I'm a professor and the section chief for breast radiotherapy at MD Anderson Cancer Center in Houston, Texas. And I'm talking today about the local regional therapy studies that were presented at San Antonio. My conflicts are listed here. And this is the outline for this talk. There wasn't as much platform presentation of local regional therapy at San Antonio this year as there have been in years past. So I'll highlight the SINODAR-ONE randomized study, which was presented on the platform, several of the spotlight session posters that were highly scored, the 5-fraction debate, and if we have time, I'll present 2 clinical trials that were recently presented at ASTRO that impact radiotherapy decisions. So this was the randomized trial that was presented on the platform, the preservation of axillary lymph nodes compared to complete dissection in T1-2 breast cancer patients presenting with 1 to 2 metastatic sentinel lymph nodes. This was a multi-center randomized clinical trial presented by Dr. Gentile. And this was done because the feeling was the limitations of the Z11 trial, which of course is similar, were significant and confounded the results. And so this study is a randomized study comparing axillary lymph node dissection to sentinel lymph node biopsy in patients with macrometastases. You can see here there were over 400 patients randomized to each arm. And the results of the axillary surgery are presented here, highlighting the type of metastases, really macrometastases here. And at the bottom, the positive non-sentinel lymph nodes that were identified in the axillary lymph node dissection arm at 44%, the mean positive non-sentinel lymph nodes, and the median positive non-sentinel lymph nodes displayed. Here are the results from this study. In the standard arm and the experimental arm, very similar outcomes, very few events, 16 total in the standard arm and 20 in the experimental arm. You can see that the axillary recurrences were 1 in both arms. Ipsilateral breast cancer recurrence, distant recurrence, and second primary were all very similar in absolute numbers, no significant difference. The actuarial outcomes were also very similar with no significant difference. And they highlight that this now is a trial that demonstrates this for patients who have macrometastases, included patients who had a mastectomy, had detailed radiotherapy data, and had reasonably long follow-up at 3 years. So while it could be considered that additional follow-up is needed to fully transition away from axillary lymph node dissection for all eligible patients, it has been the decision of this presenting group's institution to eliminate the axillary lymph node dissection for patients relevant to this trial. In the local regional spotlight session, Dr. Alistair Thompson presented 3 highly ranked abstracts, one on Hodgkin's lymphoma and breast cancer, surgical resection for stage 4 breast cancer, and outcomes for the omission of sentinel lymph node biopsy. So first, the authors of this study looked at breast cancer cases after a history of Hodgkin's lymphoma in the SEER database. They found 295 patients. You can see the mix of surgical procedures in these cases. And what they present is that the risk of contralateral breast cancer is reasonably high here for both breast-conserving therapy and mastectomy. And the consideration with this 9.4% contralateral breast cancer risk at 5 years and 20% at 10 years is what is the right surgery for these patients? And might it be reasonable to think about bilateral mastectomy for some of these patients? What is the right strategy here? An additional database study, this one from the NCDB, looked at trends for resection of the primary for stage 4 breast cancer. Of course, there have been multiple randomized trials demonstrating no benefit to resection of the primary in stage 4 breast cancer. And indeed, looking at trends in the NCDB, the rate of surgery in this setting has been declining. The largest decline was in hormone-positive breast cancer, less surgery in older, frailer patients. Importantly to note, less in African-American patients, which may represent a disparity, multi-mets and chemoendocrine therapy. Surgery preserved largely in patients who have metaplastic or triple-negative breast cancer, and highlighting the importance of figuring out if there are subsets that benefit here, who are they, and who should be omitted for this based on the randomized data. Lastly, Dr. Thompson presented the outcomes for omission of sentinel lymph node biopsy, again from an NCDB study looking at women over 70 years of age, T1N0, hormone receptor positive, HER2 negative, with comorbidities, the patients for whom it would be very reasonable based on guideline recommendations to omit sentinel lymph node biopsy. This was a propensity matching study, and the results demonstrated that you see node-positive sentinel lymph nodes more commonly in patients with central tumors, LVI, and T1C, that sentinel lymph node biopsies were more likely, patients who received sentinel lymph node biopsy were more likely to receive chemo and radiation, and that interestingly, omitting the sentinel lymph node biopsy was associated with lower overall survival, and presumably because these patients received less adjuvant therapy. Putting that in context, Dr. Thompson looked back to San Antonio 2020 with a separate study from McKevitt et al., looking at patients where sentinel lymph node is not routinely used, patients over 70, similar cohort, and finding that it is still performed in over 80% of this patient cohort. And they also found that the sentinel lymph node procedure in patients with no adjuvant therapy compared to sentinel lymph node omitted patients was associated with lower breast cancer specific survival. And so the question that was posed is whether or not the sentinel lymph node procedure should be considered in the context of the adjuvant therapy decisions, because there was no difference in breast cancer specific survival in the patients who had any combination of adjuvant therapy. So why do the sentinel lymph node biopsy in this setting if you're definitely going to give the adjuvant therapy? So those were the posters that were highlighted at the local therapy spotlight session. Probably the most interesting conversation regarding radiotherapy was in the space of the radiotherapy debate. And the motion on the table for the debate was that 1 week of whole breast radiation is the new standard of care for all whole breast radiation. So historically, patients had a mastectomy for any breast cancer. Of course, randomized data demonstrated that a lumpectomy and post-lumpectomy radiation was equivalent, and subsequent studies have demonstrated that the 5 to 6 week standard post-lumpectomy radiation course could be safely and effectively reduced to 3 to 4 weeks. A recent study has come out comparing 3 to 4 weeks to 1 week, and it arguing for the motion that 1 week is now the new standard of care was Professor Coles from the University of Cambridge, and arguing against it was Professor White from the Ohio State University. So to recap that conversation, because it certainly impacts patients today all over the world, breast hypofractionation is not new. There are 3 decades of quality assured UK research, and of course these are the slides presented by Dr. Coles, that looked at moving from what was the standard of 50 gray and 25 fractions, 5 weeks of whole breast radiation, to the shorter fractionation that was demonstrated with the START A and B studies, the 15 fractions, moving subsequently to a 5 fraction regimen called the FAST regimen, which was 1 fraction per week per 5 weeks. And then the most recent study, Fast Forward, the UK Fast Forward study was published in March of 2020, right in the middle of COVID, and demonstrated that you could give a higher dose per fraction, 5 fractions in 1 week, and have equivalent outcomes. And this is the basis for this conversation. So here's the summary of that study called Fast Forward. Eligible patients were T1 to 3 and 0 to 1. There were 4,000 patients accrued, and they were randomized to the standard 40 gray and 15 fractions, 3 weeks, which is used widely in the US as well, plus or minus a boost an additional week, to 2 different short 5-day fractions, 27 gray and 5 fractions and 26 gray and 5 fractions. And there were annual clinical assessments, photos, and patient-reported outcomes. The median follow-up was 6 years. The primary endpoint, ipsilateral breast tumor relapse, demonstrates clearly that the 2 1-week fractionations, green and blue here, 27 gray and 26 gray, were associated with, if anything, less ipsilateral breast tumor recurrence. There is no difference in the efficacy of these 2 regimens at the 5-year mark. Looking at the toxicity endpoints, we see a difference between the 27 gray regimen in 5 fractions and the 26 gray regimen in 5 fractions. So looking at the top This is a forest plot showing the endpoints that favor the 3 weeks. And we see for 27 gray and 5 fractions, any adverse event favored 3 weeks. Breast distortion, breast shrinkage, breast induration, in the tumor bed and outside, all favor 3 weeks. However, in the 26 gray and 5 fraction regimen, you can see only breast induration outside the tumor bed and chest wall edema favor the 3-week fractionation, and it was highlighted that the absolute risk of these events was incredibly low. So over here on the right side of the screen, you can appreciate breast induration, 3% marked or moderate at 5 years, edema, 1% marked or moderate. These are very uncommon events in spite of the difference. A myth that Dr. Cole sought to bust is that 5 years of follow-up is not enough follow-up to take these data and move them forward. This is the FAST trial, which is 5 fractions over 5 weeks, 1 fraction a week, highlighting at 5 years in the top row and 10 years in the bottom row, where we look at the 2 arms of these trials, that you don't see significant worsening of the hazard ratios between the 5 and 10-year endpoints, and that we don't need 10-year data in order to move forward with the UK Fast Forward regimen. Another myth that Dr. Cole sought to bust was the idea that this has not been well tested or adequately tested for subgroups, for high-grade tumors, for larger tumors, for node-positive tumors, and highlighting here all of the numbers of patients in those subgroups who were accrued to the trial. And you can appreciate that virtually all of these endpoints lean towards favoring 1 week of radiation. So no indication that this is not adequate efficacy for patients who are other than hormone-positive T1N0 breast cancers. So ultimately, the UK consensus statement has moved strongly towards 1 week of whole breast radiation for all whole breast radiation, 1 week of whole breast chest wall radiation, to consider 1 week of radiation for chest wall radiation after reconstruction. And I'd highlight in both of these cases, this does not include regional nodal irradiation, and 1 week of radiation over 1 week for the partial breast irradiation patients. So arguing against, Dr. White argued this is not the standard of care and started by highlighting that the 2 important goals of breast-conserving therapy are to secure in-breast control and to preserve the cosmetic appearance and breast sensation. So she started by backing up to the UK FAST trial, which is 1 fraction a week for 5 weeks. This was a trial which we've seen before, compared the standard 5 weeks to 1 fraction a week to 30 gray and 1 fraction a week to 28.5 gray. You can see the accrual characteristics of the patients on this trial here. There was no statistically significant difference between 5 fractions over 5 weeks for the 28.5 gray versus the standard 50 gray, but there is a difference in breast photo appearance if you got 1 fraction per week to 30 gray. There were significantly more mild to marked change in breast appearance on photos and more adverse breast effects. So you can see down here, the risk ratio for a marked change in appearance for 28.5 versus 30 was 2.7. It was statistically significant at 3 years. And it's important to highlight that that means that there is a very slight difference between an acceptable total dose and an unacceptable cosmetic outcome. So here, although the in-breast recurrence is very low, for the 5 fraction whole breast irradiation groups, there's a small difference in total dose from 28.5 to 30 gray with a significant impact on breast appearance. So moving then to the UK Fast Forward trial, 5 fractions in 1 week. Again, here's the study schema, the standard 40 and 15 for 3 weeks, comparing 1 week to 27 gray or 1 week to 26 gray. Again, the majority of these patients, ER positive, small node negative breast cancers, 25% of them did get a boost, so an additional week of treatment. And here, what we see again is that the difference for mild to moderate photo changes for 27 gray is significantly higher than what we see for 26 gray. So there's a significant impact on the appearance for very small differences of dose when you are giving the dose over such a short period of time. So Dr. White highlighted that the in-breast cancer control with this regimen is well demonstrated, but preserving the cosmetic appearance and breast sensation may be worse. They also noted that in the publication, when you look at the forest plot for the cosmetic outcome, the vast majority of these tend towards 40 and 15, and the authors note in the discussion that the hazard ratios and odds ratios indicated a trend in favor of the standard arm for most items analyzed. Lastly, she highlighted that breast cancer patients infrequently follow up with radiation oncologists. This is a SEER Medicare-linked data set highlighting that follow-up visits with a breast radiation oncologist by year 5 are down to about 4%. So it may not be the case that breast cancer radiation oncologists are going to really see the poor cosmetic outcomes that could happen in a short course radiation. So her final concluding remarks were the importance of balancing benefits and risks. Nearly all treatment decisions involve some trade-off between therapeutic benefits and risk. Some are likely going to be very willing to accept that trade-off for the convenience of 5 fractions, and some will not. And of course, it's important to have these conversations with patients, and that additional prospective data are going to further inform us about the nuances of making these decisions. Her concluding thoughts were that one size should not fit all, and that APBI has been well studied in the low-risk luminal population with 10-year follow-up data. There are multiple observation trials going on for low-risk patients, and that there are other shorter options for higher-risk patients, including concomitant boost, which again has been well demonstrated to be safe and effective in UK trials. I'll highlight in my own practice, we feel that it's very reasonable to offer the UK fast-forward regimen for partial or whole breast for patients with good dosimetry who are comfortable with the 5-year data after a discussion about the cosmetic issues. For the audience, 50% at the beginning of the debate would have chosen a 15 fraction regimen for an early stage ER positive node negative whole breast patient, and 80% chose a 5 fraction regimen for the same situation after the debate. So people were swayed to have these conversations. Lastly, some posters that were discussed in the spotlight discussion session for radiotherapy. One looking at the risk of in-breast recurrence when observing low-risk patients who do not adhere to the recommendations regarding endocrine therapy. And another study that was looking at repeat partial breast irradiation after an in-breast tumor recurrence for a patient who had had a previous breast-conserving therapy. So this study was a multi-hospital retrospective review looking at patients who met the criteria for the Lumina trial. And you can see those criteria listed here: age over 55, unifocal, unilateral, T1 and 0, low grade, very favorable. And they defined endocrine non-adherence as discontinued before 5 years for something other than recurrence or death. And what you can see when you look at the 5-year local regional control rates here is that for all patients, as has been seen in randomized trials, the risk of in-breast recurrence is slightly lower when you, or slightly higher when you omit radiation. And that number, while not statistically significant, potentially due to small numbers here, is numerically higher in breast recurrence when there is not adherence to endocrine therapy, and this warrants further study and consideration. Then the look at the repeat partial breast irradiation, again, a multi-institutional retrospective review, prior lumpectomy, 35 patients. They were a range of molecular subtypes. Patients had an isolated in breast tumor recurrence, were over 50, and were at least 4 years out from their primary treatment. And here were the outcomes. All patients were treated with a second lumpectomy and APBI reirradiation. The follow-up is about 3 years. There were 4 relapses, 1 in-breast tumor recurrence, 3 metastatic recurrences, and the 5-year regional free survival was 82%, metastasis-free survival 84%, overall survival 93%. There were 2 deaths unrelated to breast cancer, and the toxicity was very reasonable. So putting this in the context of the NRG-RTOG study, looking at the same treatment in the same population, both multi-institutional, the RTOG study was slightly larger, similar eligibility. The dose and fractionation was a little bit different here, more IMRT being used, slightly longer follow-up in the RTOG study, and very similar ipsilateral breast tumor recurrence and overall survival, highlighting this as a potential option for patients who want to preserve the breast after an in-breast recurrence, after breast conserving therapy. So with a few minutes left, I just want to highlight 2 clinical trials that were presented at ASTRO that showed some new data regarding radiotherapy. One of them is the metastatic breast cancer KROG trial. This was presented by Dr. Jillian Tsai from Memorial Sloan Kettering. The trial is to investigate the role of SBRT in oligoprogressive disease, up to 5 progressing lesions according to RECIST/PERSIST criteria. The eligibility are here, and this trial included both lung cancer and triple negative or high-risk ER-positive metastatic breast cancer. The primary endpoint was progression-free survival, and patients were randomized to either no SBRT, standard of care, possibility of SBRT at progression, or SBRT to all progressive sites followed by systemic therapy. Here are the results of this interim analysis: 103 irradiated lesions in breast cancer patients and 110 irradiated lesions, multiple lesions per patient, in the lung cancer patients. In the results, there was better progression-free survival in patients receiving SBRT, but it was limited to the lung cancer population. So this was a striking finding. It is still preliminary. It highlights the value of the randomized breast cancer-specific stratified trials looking at the role of SBRT in oligoprogression and oligometastatic disease in general. But again, you can see all of the benefit here in the lung cancer population and no benefit in the breast cancer population. So it prompts interesting questions about the biology of this group. The breast cancer patients had a greater number of new lesions following the SBRT for oligoprogression, as you can see here. The second study that I was going to highlight today is the Regional Nodal Irradiation Trial, KROG 0806. The purpose of this study was to investigate internal mammary radiation in patients with node-positive breast cancer. The trial schema is down here: node-positive patients, mastectomy or breast-conserving surgery, more than 8 nodes removed, no neoadjuvant chemotherapy and no distant metastases, stratified on nodal stage and the type of surgery. Patients all got supraclavicular radiation, and they were randomized to internal mammary radiation, yes or no. The primary endpoint was disease-free survival. 50% of patients received breast-conserving therapy. Of note, the patients who did not receive internal mammary radiation had more ER-negative patients, which may impact the results. There was no difference in the recurrence, disease-free survival, overall survival between groups. There's a numeric increase in breast cancer specific mortality. You can see that here, but it didn't rise to the level of statistical significance. What is interesting in this subgroup analysis is that, consistent with the EORTC 22922 trial, which enrolled patients who were node negative with medial tumors and demonstrated regional nodal irradiation improved disease-free survival, here in the patients with medial or centrally located tumors, the patients who got internal mammary radiation had significantly better disease-free survival. So this is a provocative subgroup analysis that lends credence to some of the studies that we have already seen, highlighting the role of internal mammary lymph nodes in patients at risk for disease in that location. So these authors concluded that including the internal mammary radiotherapy in RNI patients with node-positive breast cancer did not improve disease-free survival. However, those who have a medial or centrally located tumor may be considered for internal mammary radiotherapy when performing regional nodal irradiation. Of course, there's limitations to the study, and further work are indeed warranted. So I hope that's helpful. Those are all of the local therapy studies that were highly ranked at San Antonio, and a few bonus ASTRO studies that were clinical trials and quite provocative. And I want to appreciate all of the authors. These slides come from the primary presentations. You can see the presenting authors' names at the bottom of them if you want to contact them. And of course, appreciate all of the advocates and trialists and patients and massive number of people who are involved in making these data happen. Thank you.